Sean bienvenidos a un nuevo plano.
Bienvenidos a un nuevo plano.
Un nuevo viaje.
Un nuevo viaje.
Un nuevo viaje.
Donde la visión es bidireccional.
Bidireccional.
ARI. Exposición comercial de tecnología oftalmológica.
Muy buenas, tenemos el gusto de presentaros la sesión satélite de Carl Zeiss, sesión satélite que es una estrella de nuestra exposición comercial que os invito a visitar en nuestra página web, en ese mundo virtual del metaverso que hemos creado para la exposición comercial y ciertamente que es una sesión muy importante y muy interesante sobre digitalización de los datos en la clínica. Digitalization, make data work for you, que los datos nos valgan para trabajar con nosotros, que los datos nos ayuden. Tenemos un distinguido panel de expertos y finalmente tenemos también un panel de discusión donde vamos a debatir lo que aquí se vaya a comentar. Tenemos también el gusto en este panel de expertos invitar por primera vez a ARI, a Antón Barraquer, Carguisin y también actuará Marta Pazos junto con un servidor de todos vosotros. Va a presentar Jorge Luis del Barrio, mi co-chairman de esta sesión, a los ponentes y sus temas. Muchas gracias.
Vamos a empezar entonces con la primera charla de la doctora Marta Pazos de Barcelona sobre Managing Patients with Glaucoma Workplace.
Y continúa los demás.
Vale. Y luego continuaremos, vamos a hacer todas las charlas seguidas con el profesor Mario Romano sobre Managing Patients with Retinal Workplace, a continuación el doctor Laszlo Kirali sobre Cataract Workflow and Digital Optimization Tool y ya finalizaremos con la charla de Galo Rodríguez sobre Shaping Digital Transformation Ophthalmology y al final concluiremos con 15 minutos de debate. Vamos a hacer todas las charlas continuadas y ya nos vemos directamente a la hora del debate. Gracias.
Hello, everyone. Thank you so much to Zeiss for the invitation. It's my pleasure to be here today at the ARI Congress. And for the next minutes, I'm going to talk about integrated digital workflow and how Glaucoma Workplace can help us manage our glaucoma patients. So for this presentation, I will talk about structure and function relationship, and finally about progression evaluation. So for structure, please remember to take a look at the most important parameters. So for the rim, we will have an idea of the optic disc appearance. This is very useful to know the size of the disc, but also to detect asymmetry that we know is very suggestive of glaucoma. And these parameters may be better in tilted disc or strange discs, in which sometimes retinal nerve fiber layer can be artifacted. So for retinal nerve fiber layer, remember this is the most used parameter. It has not been overcome by any other single parameter yet. It does change early on time, typically years before the visual field defect. It has excellent discriminative ability, very useful in mild to moderate glaucoma, and the parameters that we need to have a look at are average thickness and inferior thickness. For ganglion cell layer, we are also now very interested in the macula. It changes in a very sensitive way in early glaucoma, in ocular hypertensives, also in glaucoma suspects. It's capable to catch very focal damage, paracentral defects that are more likely seen in normal tension glaucoma. And we need to look at the roughest side. The parameter that we normally look at is ganglion cell IPL because it's the parameter that changes first. And again, it's useful in tilted disc, in which sometimes retinal nerve fiber layer can have artifacts as well. So please remember to have a look at deviation maps, not only look at numbers, not only look at color-coded sectors, because if we do so, sometimes we may miss glaucoma damage. And for this, I really recommend you to look at in the retinal nerve fiber layer at those defects that look like wedge defects. And in the ganglion cell layers, look at that roughest sign that it has also been called like an appearance of a snail shell. Those are very sensitive to detect glaucoma, and also even in tilted this or myopes, in which sometimes other parameters are not as good, those mean deviations still change. This topographical analysis is important. Also remember to combine parameters, not only use one, use them all together. We have in Cirrus some examples of these schematics like the panel map, and combining parameters actually enhances sensitivity diagnosing the disease. This is a patient of mine that has 69-year-old years of age, untreated IEP of 14, and we have these visual fields that actually have a very central damage. If we look only at the sectors, we may think this is normal because OCT, retinal nerve fiber layer, is completely green. But actually, if we look in more detail in the deviation map, we can see this wedge defect over here. And if we look at the macula in more detail, we can see the snail shell appearance is Raff's sign that's in this superior area. And this actually correlates very well with the structure with these inferior defects. So yes, this is a normal tension glaucoma, basically. Now let's go to function. So one of the new things in function is that we are realizing that 24-2 is not good, for the central damage, because it may underrepresent that damage, because only 4 points that are actually representing that area. And that may not be enough. That's why we have now the new 24-2C, which actually adds 10 extra points to that area, only adding 30 seconds. And we have seen that that's very useful in screening, and that in those patients, we may not need to do 24-2 and 10-2 to detect the disease. This is an example of a patient that has a 14 millimeters. It has an unaltered retinal nerve fiber layer defect, but the field looks normal. But if we look at the 24-2C, we now can see those central points over here that we may have not seen if only doing the 24-2. Does that mean that we never need to do a 10-2? No, there are some reasons why we would do a 10-2, basically to further characterize that central defect. For example, when one of the 4 central points of the 24-2 is severely damaged, when we actually have structural changes suggesting really a defect that's very likely in the center, or when we have changes in the 24-2C that I just mentioned. This is a patient with a very significant inferior notch, changes in the retinal nerve fiber layer, also in the ganglion cell layer, but only a minor central point that we may sometimes overlook. If we do a 10-2 in this patient, we really can characterize that defect, and it's much more than we thought. So remember to do that in those cases. Structure-function relationship, we've seen some examples, but please remember that early in time, structure change first, OCT is more valuable. Later in time, we have the floor effect, and OCT below 50 to 60 microns, it cannot change more. In those situations, visual field defect is better. And we expect retinal structure and function correlationship in those middle situations. In moderate glaucoma, in situations in which there's established glaucoma, those 2 lines go in parallel. How about progression? Remember to take into account significant progression, but also clinical progression. So we know that fast progressor are minus 1.5 to minus 2 decibels per year, or its equivalent in VFI. But we also need to take into account high risk of future visual impairment, considering other factors like life expectancy, severity of the disease, known risk factors like pseudoexfoliation or certain ethnic groups, as well as the global situation of our patients. Also have in mind that we need to forget about statics and go to dynamic assessment of the field. We need to interact with data, be able to exclude unreliable tests, use parameters as we wish, design our tools, also mark significant events like, for example, treatment, or do dual baseline to compare pre-surgery and after surgery, for example. I will show you how glaucoma workplace can help you with this. This is a pseudoexfoliation glaucoma, and we see that there's a big decrease we did in a BFI, in a mean deviation, we did surgery here, and then this is actually stable. So we can mark this with glaucoma workplace, as I explained. So for example, here, we can basically say where our surgery was. We can mark that. We can even put a nice knife. And we can do dual baseline. Here, we see a very rapid progression of minus 2.3. And then after surgery, we can see very graphically how it stabilizes to minus 0.1, and we can do that with dual baseline. For structural progression, remember that both retinal nerve fiber layer and ganglion cell IPL can be evaluated over time in terms of trends. It's important to know the variability of those measurements, which is 5 microns and 4 microns respectively, but also have in mind that those slopes are not corrected by age. So there's a normal decline of both of them due to aging. For retinal nerve fiber layer, this is minus 0.54 microns per year. For ganglion cell layer, this is slightly less, 0.32 microns per year. Please remember that if we look only at statistically significant slopes, we may actually have a lot of false positives. We need to look at clinically significant slopes. The way we do that is typically going under the 5% of normal range of variability for the age. And that accounts for about minus 1 micron per year for retinal nerve fiber layer. So if our trends is more negative than minus 1, very likely this is due to something else and not aging. So for example, glaucoma. We would use retinal nerve fiber layer to assess change in mild to moderate glaucoma before it gets to floor effect again. And there's still some way to go, some range for ganglion cell IPL. And it has also seen some use for myopes, in which retinal nerve fiber layer sometimes is not as good. And we can see an example for that in our final case. In a 53-year-old female, we can see how visual field appears stable. It's mild glaucoma, almost no changes in the field over time. We can see structurally how the retinal nerve fiber layer is decreasing at a very important rate that is about 3 times that minus 1, it's minus 3. So this is a significant structural progression. We can see also changes in the ganglion cell layer, more negative than minus 1. And if we see the events, we see that changes are happening inferiorly, and that later on time, basically, we start seeing those superior changes in the field. So as take-home messages in conclusion, please remember to evaluate structure combining all the available parameters. That 24-2 sometimes underestimates central damage, and we have to do 24-2C or 10-2 sometimes. That structure and function depends on glaucoma severity. Early on time, OCT is better. Later on time, visual fields are better. And that you have to evaluate clinically significant rates of progression. And this is all. Thank you so much for your attention, and I'm all ready for questions.
Thank you so much for your kind invitation. Today we'll speak about managing patients in retinal workflow. For us as health workers, the digital ecosystem integration is a great opportunity, but the key points to be defined are the workflow for retina and the protocols for data collection and sharing. Inside the hospital, of course, between clinics and hospitals, but also between hub and spoke nationwide and worldwide. So what's new with the retinal workflow? Each task as a assess, plan, treat, and check can be performed remotely and allows a unique control of a patient care path longitudinally. But the real strength of the retinal workflow is to have confluent information. So looking for standardized acquisition protocol, but starting from what we see. So to know exactly where we are on the fundus is really important, and we can add information on our fundus examination point by point. So regarding the assessment, we can have at each follow-up time structural and angiographic information of anterior and posterior segments same time, point by point regarding the evolution over time, comorbidity assessment of anterior and posterior segment that can guide us to the surgical treatment. This patient was planned to have cataract surgery done, but we found at the time of the assessment a retinal tear with secondary epiretinal membrane. So looking at the location of secondary epiretinal membrane and the amount of intraretinal gliosis and the random hyaline fiber layer path, we better plan also the right time and the best way to peel, minimizing the postoperative metamorphopsia. This is another patient who had asked for refractive cataract surgery done, but during the assessment we found myopic schisis. So our plan for the lens implant was different. This is a patient that was seen in a sport clinic for regular checkup, but we found the presence of optic pit with intraretinal fluid. So we brought all this information in the theater and we went for island peeling with the inverted visco-assisted flap on the optic pit. So we did the island peeling and we folded the ILM on the pit. In order to stabilize the flap and also to promote the closure, the communication between the subarachnoidal space and the vitreous cavity, we add visco material on the top. As you can see here, the flap of ILM is on the top of the pit, and we also see a slow anatomical and functional improvement after surgery. So this is another patient with the previous treated rheumatogenous lesion. This is still asymptomatic and we can better define the lesion and the distance from the fovea and progress over time before doing a cataract surgery. We can better tell the presence of rheumatogenic detachment with outer retinal layer associated to retinoschisis, as you can see here. It's not just retinoschisis, but also retinal detachment associated. During the assessment of this patient for cataract surgery, he refers a paracentral scotoma within 10 degrees. We found a retinal tear. The patient was not treated before with the laser. And we found a U-shaped configuration retinal break with also some subretinal fluid accumulation. So that means that the condition is stable, but after cataract surgery something can happen. So we were closely monitoring the patient. Also, planning the retinal surgery, the combination of ultra-wide field fundus image and wide field OCT can better characterize peripheral round holes that can be associated with vitreous attachment, like in this case. The retinal workflow regarding epiretinal membrane, so looking for standardized acquisition protocols. Starting from what we see, the OCT is not enough. OCT is telling us that a stage 3 epiretinal membrane with intraretinal gliosis, but not much about the timing of the surgery, only related to the intraretinal gliosis. We can measure the shift of the retinal vascular crossing from retinal pigment epithelium, and we published this paper, and at the end with the postoperative 3D assessment of the retinal movements after the surgery, we can tell that the postoperative vascular activation acuity correlate with the movement back of the retina after the surgery that depends on the grade of intraretinal gliosis. This tells us the right timing of the surgery. So in our algorithm of the retinal workflow, there is intraretinal gliosis, there is area of traction, and there is also retinal vessels dislocation to plan the timing and how to do the surgery. Regarding the full thickness macro hole, only this image B-scan is not enough to tell what we have to do at the prognosis. So we need really multimodal imaging in order to better plan the treatment planning and to give a right prognosis to the patient. Planning the surgery in these cases, we can go with ANFAS at level of outer nuclear layer, having information regarding exudative like morphology because of hydratation of the retina around the macular hole. At the same time, going deeper, we can have information on a supra-RP granular deposit on outer segment photoreceptors regarding the prognosis. So together, they give us also information on how to reduce the retinal stress and which kind of tamponade we need to use. We can also have information where we don't have to pull during the surgery. And regarding the cavitary anomalies of the optic disc, so the presence of conical excavation of the dysplastic optic disc together with straight retinal vessel and peripapillary pigmentation, and also at the same time schisis-like thickening and lacrimal cribrosa defects, so communication with cerebrospinal fluid, means that there's dynamic fluctuation with the fluid that go in and under the retina. So probably in this case it's telling us that we need to use amniotic membrane or something to plug these abnormalities. And then finally, we need also to check, so it's very important to have a follow-up. You can see this bilateral cryo and buccal for retinoschisis, follow the peripheral fluid after the retinal detachment, and as you can see here, there's progressive fluid accumulation in periphery, and we need to know exactly where we are. And you see in the right eye, despite a normal foveal profile, we have a retinal detachment that is growing. So the advantage for us as ophthalmologists is not just monitoring assessment or differential diagnosis. We can stream our workflow, we have more connectivity, we have an output for artificial intelligence, we can simplify our environment and have a statistical analysis for pathologies. So prediction sometimes also for our and machine failures. And we hope also in the near future to have also this preoperatory information inside the scopes. Thank you.
My talk today is about cataract workflow and digital optimization through IQ. So I want to tell you my story. I started in 2012 with my clinic in Leipzig, Germany. And we were one of the first forum adapters in the world. So forum at that time was only for a PDF collection, as you can see here in the right corner. And just to compare what's going on in 2012, we had iPhone 4. This was the typical Mercedes, and we had Rana on the charts. So, but what's today? After open a clinic in Berlin and in Cologne, now we open up a clinic in Hamburg this year. iPhone is now on number 16 and some music in the charts and a new car. But what is really different to 2012, that's your digital workflow with IQ Workplace. So I want to explain what does it mean and what's the advantage for you. So here you can see the 5 big points for your direct workflow optimization. As you can see, you have like a one cockpit. You know, everything is now in your IQ Workplace info room on one place. You have your pre-calculation. You can calculate your IOLs, your surgery preparation for your Callisto, IOL ordering, and your personalization is what you can do here in the IQ Workplace. So this means for you save time through the process, better protection against never events, personalization, and the really important thing about workflow is that you have more time for you and for your patients. So what I want to show you here is in 2015 with the University of Leipzig and the company Swan and Carl Zeiss Meditech, we analyzed our cataract workflow from the pre-examination to IOL calculation, ordering process, surgery, and post-op examination. What you here can see is only the process for IOL selection and ordering. So this is a process you do it all the time, but I think a lot of people are not aware of that, how complicated it is and how difficult the analog workflow is without IQ Workplace. And I think a lot of people still using this process. So that's why I want to show you the process. I think it's very small, but I explain you. This means here, this is after all the pre-examination. So we're starting, all diagnostics are done. So then we have different workflow between toric and non-toric IOLs because we need here astigmatism correction, in this case not. So we have our EMR, we have our forum, and what we have to do is we have to check up the patients in our EMR. Then we go to the forum link. Then we go to forum. Then we have to check the IOL master. We have to print out. Then the same, if you use Pentacam, for instance, you have to go to the Pentacam just for the patients, the PDF, yeah, print it out and collect all the data. So this is very time-consuming process. And after you've done all of this, this is the following size process. This is the, in our case, the ICOM process. Yeah. So you had all the data, then you scan the PDF, you send it to the size calculation team, they send you results, then you get to print out, and you have it here. And here for the ICON lenses, you have here the way for the toric calculator. You have to put all the data manually in the toric calculator online, or you send it to ICON, and they make calculation for you, and then you send you the results. So also a lot of mistakes can happen on this workflow. It's very, very time consuming and very difficult. But normal for everybody. So nobody thinks about it. That's why I want to visualize it for you. And after we get the results from the calculation team or from the online calculator, so the staff put it in your inbox for the surgeons take it, then here in which lens you want, then it goes for the ordering team, then we send it to the company, so and then the ordering process is finished. Companies manufacture the IOL, send it to your clinic, and you store the clinic, you put it on your OR plan and store your lens. So this is the end of your process. So I think nobody is aware of that, how much steps you need, because in your daily routine is for you very easy and you don't think about it. But the new way is digital. As you can see here, you have your Forum IQ Workplace. And I think the most important game changer for IQ Workplace for you is that you have your patient in your consulting room, you have your IQ Workplace, and you have all the diagnostics data. And you can load in the IQ Workplace everything you want, like even from other manufacturers like Pentacam, cataract pre-op screens, whatever you want. And so you have all the data. And when you have the data, you are really know everything about the patients. What is needs? What is his job? What is the expectation? And what is the diagnostics? So you're really focused on the patient. And now you have to choose your IOL here like this, and then the process is done for you, because now it's in the system. You have considered everything like topography, OCT data, biometry data, everything you want. And now this is your adjacent, like in this case, size 80 Lara Toric. So now it's just go for the ordering process, make your pre-ops for your surgery day, your alignment, your surgery-induced astigmatism. You can customize everything, so with standard data. So this is a very, very fast process. As you can see, pre-calculation, IOL calculation, surgery preparation, and you are done. So on next day or on day of surgery, patient check-in. With your Zeiss Callisto, you check the delivered lens for the patients with your data from the IQ workplace on the Callisto, so you're really sure. You have also the opportunity to use QR and barcode scanning if you want. So this is fully digital process from the very beginning to the surgery. At least at the end, you can optimize your IOL consent if you want. Every 2 or 3 months, there's software you can put in your data, and you can improve your outcomes. So my suggestion is switch to digital IQ workplace, save time. Time means more time for you, not do IOL calculation after the consultation of the patients in the evening. Do it just in time, save time, have more time for the patient, more value, more quality, less mistakes. And so that's my suggestion is go digital, and save time for you and your patient. So thank you very much for attention, and yes, I'm looking forward for our discussion. Thank you very much.
First of all, thanks to Professor Leon and ARI Congress for having us to talk a bit about how to shape digital transformation in ophthalmology. Is it true that we only use a small percentage of our brain? If it were real, wouldn't you want to be able to use 100% of its potential? Let's think about your profession and the equipment you use. Wouldn't it be great to get the most out of it? This is possible, and it's thanks to digitalization. As a simple but familiar example, let's think about how we connect devices in a house. These are processes that we are used to do manually, such as programming the washing machine, turning on the air conditioner, or activating the alarm. To make it faster and more efficient, we are going to connect all these devices to a network. Now you can remotely control the temperature of the heating, for example, which means you can adjust the temperature of the house even when you're not at home. But in the long run, there is a greater value. All the data about your temperature settings is stored in the application, and it analyzes the data and starts making suggestions about the temperature settings. This data can save money on your heating bills, so what was once a standalone functional device now becomes a digital ecosystem that can save money, time, and improve your efficiency. And this is how digital ecosystem works. It has 3 components: a device that generates the data, a platform where that data is collected, and finally, software applications where this data is used. As the scientific community is always looking for new solutions, ZEISS has one that you should know about. We have our ZEISS medical ecosystem. This is a digital ecosystem which connects, automates, and applies artificial intelligence to make all images, tests, and data in a safe and compliant way. Our first element is medical devices. They generate untold amount of high-quality data in the form of PDFs, images, raw data, for example. We're talking about connecting any device to our ecosystem, not just only ZEISS gold standard devices as Humphrey Field Analyzer, IOL Master 700, Sirius, Callisto Eye, but any other connectable third-party equipment. The second element is a data storage layer. And for this, we have two different platforms. Forum is an on-premise solution with more than 10 years of expertise that helps to streamline the care and diagnostic process, protecting also data from attacks. Health Data Platform is a cloud solution. This is in collaboration with Microsoft to get the most out of all the data. These platforms allow data to be stored in efficiently and secure, compliant environments. Finally, the third element, this is our digital applications. SESION innovates also through software, and it brings value to all parties in our workflows: physicians, patients, technical teams, and practice managers. The applications are able to sort through all the data to improve the patient experience, standardize the practice, and deliver high-quality care. Workflows provide value beyond traditional standalone devices, offering all-in-one solutions. At SESION, we differentiate workflows for each of the major subspecialties of ophthalmology. Thus, we could group devices and applications to be able to contribute ideas in glaucoma, retina, cataract, and refractive. In retina, Professor Romano told us how to use Retina Workplace, enabling the greatest possible amount of information for the diagnosis of retinal pathologies. Dr. Apazos showed us different cases using Glaucoma Workplace, generated glaucoma progression reports in Forum with information received from Cirrus, Humphrey Field Analyzer, and Clarus. Dr. Laszlo Piragi showed us how from biometry capture from ILMaster 700 we can work with EQ Workplace. But let's take a closer look at cataract workflow and how digital applications enable greater efficiency by combining devices and managing data. In cataract workflow, we can maximize clinical efficiency and performance, saving up to 50% of time in the steps, like data entry, for example, and reducing these processes. This means also cost saving. Here, in cataract workflow, we have an example of how we can combine Forum with Health Data Platform. After planning with EQ Workplace, recordings from the surgical microscopes with Callisto Eye can be transmitted to the Health Data Platform, and after the surgeries, this data could be reviewed and analyzed. For example, Surgery Optimizer applies artificial intelligence to segment the phases of a surgery, and can also be used to directly compare one surgical video of cataract with another. In SESION, we know innovation and technology needs to be deployed with training. That's why we have developed MySESION. This is a platform where you can find tutorials explaining how the digital tools work, as well as interesting information on SESION equipment. It is a free platform, and you can register now with this QR code. We don't know what's about to come in the future, but we are well prepared for it. Knowledge, experience, and innovation combined with scientific evidence and collaboration of our users merge in SESION, while more and more ophthalmology is a diagnostic imaging specialty. So with all the challenges that ophthalmology faces on a daily basis, do you dare to make the data work for you? Thank you so much for your time, and if you need further information, please contact your SESION representative.
So thank you very much. It has been a lot of information, and indeed we're going to conduct this session now in English because we have the pleasure to have Laszlo Kirali, and probably he would like to participate with us. So thank you, Laszlo, great presentation. And the first thing I have to tell you, because I was informed in part about this platform, is how impressive it is, how much information we can manage and how much guidance we can get in our practice. So let me ask to you, as a non-expert in this area, several questions, because in my opinion it's important for the audience as well. Number one, we can direct a lot of our decisions through the clinical information that we have, but do we have a feedback from the outcomes as well? In other words, can we analyze our data, our outcomes, for instance, in cataract surgery, in refractive, in retina, together with the patient-reported outcomes? This is my first question.
Yes, also in cataract and refractive, we have a lot of options. In cataract EQ Workplace, you can optimize your IOL constant when you put in your data from your post-op examinations. And in refractive Workplace, there's also an option that you can optimize your nomogram for your SMILE laser, for instance, for your VisuMax. So you can also put your post-op data, then you can improve your nomogram for your femtosecond laser. So, and in the future, we can put
no, continue.
Yes, and in the future, I think the next step everybody's talking about is AI. So we can look, ZEISS can look what we can do more with our data we have. So I think this is the next big step we will see in the future.
Thank you. Apologize because there is a 2 seconds delay between my message and your answer, and this is why some disconnection exists. So this is right, but can we get also patient-reported outcomes, for instance, patient satisfaction questionnaires, quality of vision questionnaires, etc.?
So the questions for me, but questionnaires, we don't have any option for questionnaires at this time, but I think this is a good idea to put also in questionnaires to collect more data, to improve. I think there's a lot of more we can add on this digital workflow afterwards, even after the process, and to optimize our outcomes.
Very good. Anton Barraquer-Cargassin is with us as representative from the audience, from the junior audience. This is the first time that he's in our sessions in ARI, so thank you and welcome, Anton. And I would like to know your opinion because we're in a different generation. My generation had the first laptop when we were 35, 36 years of age. You have been born with laptops and with iPhones. So for all of you, this is a totally different stuff because we need to learn something that you have been growing with it. So first of all, I think that is intuitively a very important topic. We shall have all our workflow organized in a much better way, integrated, and we shall have this information approaching us in a way that is much more guided to the decision-making process of the clinical perspective. But what is your opinion? What is if you have to address one question to this distinguished group of experts, which one would you do?
So I think I was right in, you can hear me correctly, yes? Yes?
Very well.
Okay. I thank you very much for the invitation. What I find interesting, I was born in the middle, right when technology started, so I am indeed maybe more familiarized, but it is true that now we want everything now faster, all the information we want it more optimized, and for this process is already the big companies like ZEISS is taking care of maybe optimizing all this data to maybe better analyze our results and obviously better plan our surgeries. I think this obviously is a very important step forward, and I think essentially the management of time, no, because we don't have time for we have to optimize it, and we don't have time for everyone, and I think it's a very interesting thing that we're trying to orient it so that we can better serve our patients. My question would be, how can we in a way approach in the cataract module of the ZEISS? How can we approach it so that, for example, the calculations, especially, for example, for toric lenses, there's many different approaches. Is this something that the system is having in consideration, or?
Yes, you have a lot of options. In the US, they have also the Velocity. This is a new cloud-based calculation tool, and I think next year it will come also to Europe. And I talked to our colleagues from the US. They're very happy. It's AI supported calculation tool, and I think this is the next way on AI calculation, that we have AI assistants in this calculation with a lot of data, and this improve also our toric outcome. And I think that's the next step. We will see it soon. Yeah.
Thank you very much.
Very good. Thank you. I would like to go step by step now with the lectures that have been performed. First to Marta Pazos about glaucoma. Obviously, glaucoma is an opportunity with this system because you might have using special artificial intelligence. Part is now introduced in the visual field test, which is the projection of the outcome of the patient depending on pressure, age, and risk variables, right? So you provide not only a prognostic performance, for instance, to make a decision about glaucoma surgery, if the medication is not enough to get taking into consideration the risk factors, the adequate safety profile in the long term, and can you provide also, which is the best treatment option based on the qualified guidelines, for instance, the American Academy of Ophthalmology or the Glaucoma European Association or Glaucoma European Society? Can you integrate this criteria? Because would be a lot of help, because obviously we can base our opinion on a much more broad basis, because many times the information that comes from these particular guidelines is very important in order to have an evidence-based practice. So what is at this moment the possibilities that offer this system for the treatment of glaucoma?
Yes, a lot of interesting points that you just brought up. So the first thing is that the forum in the glaucoma workplace allows you to have everything in the same place, and that's very helpful for us, especially for the visual fields. In the past, when you were seeing a glaucoma patient, you were looking at a lot of different tests, opening the OCT viewer, then having multiple PDF reports of your visual field all together, and that was not, convenient in terms of time, and also just for complicated even space for you. The thing is that the guidelines, for example, the European Glaucoma Society guidelines, that are the ones that we typically use in Europe, actually tell you to look at everything at the same time. So that's exactly what a forum does for you. So it's good that you have that platform, and it does it in a very, very visual way. So you have these kind of slopes that you can see over time. And it also gives you this structure and function assessment, which actually it's easier, even for a non-glaucoma specialist to see that something's going on. For example, before performing cataract surgery in a very mild glaucoma, which maybe the glaucoma is, also having these all together actually gives you the opportunity to use those practices that you just mentioned, those practices that American Academy or the EGS tells you to do, because you use data to integrate AI into all this to actually tell you which patient will progress more rapidly. So you will be able to give more, more aggressive treatment to those. That's in the future. I know ZEISS is working on this, and actually the forum is ready for that to be applied, also including all the other quality assessments that you were asking at the beginning. I know they're working on this, and actually it's good to have all digital. That's a way to have a platform to integrate all of that good ideas that you're all saying. So for us in glaucoma, it's something we use in our everyday practice, because otherwise it's very difficult to use all these different tests together.
Very good. Professor Romano is not on the stage, this online stage, but it was very interesting, his presentation, and retina is a tremendous, in my opinion, approach to the guideline, to get the treatment and to decide whether a case is going well or worse with a defined treatment, to see estimates. The lecture about retina has been for me extremely advanced and very informative about the potentiality of this software, you know. And let me ask to my co-chairperson Jorge Alio del Barrio, what do you think and how useful? Obviously it is useful, but where do it is more useful in your practice and from your perspective, this tremendous power of this platform?
Well, to start with is because as Marta said in the past, we used to have one test, and then if you want to check any other thing, you have to stand up, leave your clinic to go to other room, in other place, and was extremely inconvenient and extremely time consuming to keep moving along different devices in different rooms, spending a huge amount of time. We don't have, unfortunately, the forum, but at least I have the chance to have my topographer in my computer. I mean, have the software, and only by having the topographer, the MS-39 in my computer, that saves me a huge amount of time because I can analyze, look at the data, contrast, study the cases, prepare the cases for surgery, etc. So if I had that for the rest of the devices, including the OCT, that would be amazing, and it's what you all have, and we were wondering to have. And then for the future, I think this is essential for artificial intelligence, because in the end, probably statistics, I would say that in a few years' time, we will not require anymore the statistic people. The statisticians probably are going to almost lose their jobs, because it will be a question of having everything tabulated in a good data sample that will be automatic from the devices. Everything will be stored in data sheets, and will be a question of asking the IA, look, give me this data, analyze me this, and they will do it in the best manner, and that is gonna save a huge amount of time and money for research, mainly in our specialties that you are using a lot of numbers. And in ophthalmology, where most of our data is actually objective data, it's not like nucleoplastics, where it's more based in opinions. So I think it's gonna definitely be the future.
Very good. And now let me ask Galo. Galo has shown to us the technical aspect of this platform. And let me ask to you, how easy and how much training you need to optimize as a user the use of this platform in the way that you have explained?
Hi, Professor. So these platforms are really useful and really easy to use. Like using with one part of this platform is really easy to get the most of the data of the devices that you usually get the data. For example, Dr. Apafe showed us with glaucoma workplaces with the HFA, you can get the most of glaucoma, for example. Or the part for retina, we have the retina workplace, and it's really useful to get this all the information with the OCT is using a bit of these platforms. So just getting a small percentage of all the platform, you can get a lot of information.
Good. And well, it seems to me externally that in order to have full advantage of this platform, you need to work with a clinical file, the digital clinical file of size, right? Is that correct? Or you can work with any digital file?
You can work with any digital file. You can get third-party devices, and you can even connect these platforms with another platforms. So you can get your own artificial intelligence platform based on the information that you have in front of you.
Yeah, but would it be more advisable to use the size clinical file, digital clinical? Yes, it is. Fine.
Yeah,
so that is the point. You offer a full system that includes administration, right? Includes patient management, includes timing of the patients, includes retina, glaucoma, anterior segment, cataract, refractive, everything. Is that correct?
Yeah, that's correct. We have the
okay, so it's a global.
Yeah. we call it workflow. So we cover
global
every
approach
around ophthalmology.
Okay, so definitely you need a training because it's a quite wide application that needs to be understood to take into the practice, in order to take advantage. So it's a fantastic device, and I think that is a great opportunity. I'm not aware of any other platform as complete as the one that SESIÓN is offering now. And about the operating room, is the internal structure of this software getting, for instance, the stocks that we have in the operating room, lenses that are available or not available? Can we integrate this information as well?
We can integrate some information for refractive and cataract for places, but we cannot control the operating room, but we can control of all the parts of the surgery. So, for example, we can get the lenses from eco-workplace, as what Kiragi told before, but we cannot control inside the operating room what's happening outside of the platform.
Of course. Of course. And Anton, if you would like to ask one particular issue to this platform, what would you appreciate most? For instance, I am cataract surgeon basically, so the information about which is the procedure that I can do for a particular cornea or not, because it might not be contraindicated, is a guidance for me, because that uses a lot of information, as Jorge was mentioning. But for a general surgeon, for an ophthalmologist, and being a young junior ophthalmologist, what would you really could demand from this platform first on top of the list?
So you mean what besides the features that it has? So something extra? You mean that's the question?
No, something that is available or you need already in your practice. In which way your practice would be implemented by the use of this platform?
Yeah.
Mostly.
So I think what's most interesting is what Jorge already mentioned. I think the time management. So the fact that all of this information is grouped up, we can very quickly assess some complex cases and maybe not so complex ones, and just in general the ease of work, and that translates into your efficiency as a clinician and also as a surgeon, because you don't have to stretch. No, you have everything implemented, and that is obviously going to show in your practice, in your it's the small hardships of clicking around, looking for things, the fact that everything is optimized just in one place, that makes the work a whole lot easier, for sure. That is something that is very, very much appreciated, for sure.
So, in summary, what you demand is accessibility.
Yes,
to
I think nowadays
information. Okay.
Yes, and the more our younger generations are even more demanding in that sense. So they are most likely going to ask, which is already coming, no? But they're going to ask for this optimization and obviously as much as possible, without losing the fact that you are the one taking the final decision. Of course, these are tools that help us orient us, but the final decision rests upon yourself, obviously.
Very good. Jorge, what would you consider most useful for you using a platform like this?
Well, what I mentioned, to have what we do have with the MERS39, but with all devices. And really, in the future, I would really like to work with the artificial intelligence. I think that could be a great step forward for research. Now, this is still not there. This is something for the future, but definitely that would simplify a lot of many things. No, so well, those couple of things. One is the present thing, and the other is for the future.
Okay. Well, what I would like is to have feedback feedback about my outcomes, feedback about the outcomes of my colleagues, if possible, feedback about the benchmarks that we have, because if you don't know which is the goal, you are not going to get anything, But I think that today, as we are much more in an environment which we are demanding good outcomes, I would like to know if my outcomes are as good as my target, or the target that should be established, as the gold standard. So this information includes patient-reported outcomes. I think that the patient experience is really important for the success of the surgeon, especially in the private practice, and I would love to have integrated patient-reported outcomes as part of the feedback that I can get from this integrated platform. So I want to thank you, all of you, because you have given a tremendous perspective about the potential, the power, and the capabilities of this platform from SESIÓN. I'm sure that will be very successful. I'm sure that this is not only going to be successful, it's successful already, but it's the beginning of a history that will continue with artificial intelligence, and finally will be a transformation, in my opinion, of the practice of medicine. So I want to thank you and SESIÓN to put together this special session about digitalization and to make data working for us as a doctor. So thank you very much, and I think that we are going to close the session now. Thanks for your good lectures and your answers as well.